Hello everyone. One of the common questions that comes up every day is how long will my IV fluid remain in the intravascular system? Today we'll examine how the fluid distribute in various compartments and how fast does this happen. Since it's intravascular compartment of the IV fluid that helps you improve the cardiac output, this becomes clinically very relevant. In the previous lectures, we figured out that 20% of the crystalloids remain intravascular. In this lecture, we'll figure out how long does it really remain inside this compartment. If you want to read up some literature, these are the two good articles. The links are in description below. To understand the fluid movements, first we'll make a simple model and go on to make more complicated model so that you can understand how long do the fluids remain intravascular and the factors that govern them. If the capillaries were very leaky, most of the fluid that you give will equilibrate immediately to 20%. That is the ratio of your volume between the intravascular and the total ECF. So about 1/5 of the saline will remain intravascular under normal conditions. If you have renal losses, you'll continue to lose fluid over time, dropping down to 0 in few hours. If the capillaries were not leaky and assuming no renal losses, the total volume that would remain intravascular would be 100%. If the kidneys are working, you will again lose most of this fluid through renal losses in few hours. But the capillaries are somewhere in between. So whatever the fluid that you gave into the intravascular compartment will slowly leak into the interstitium over some period of time. Half-life of the fluid is defined as the time required for elimination of 50% of an infused fluid volume. It takes 3 to 5 half-lives before the equilibration occurs, and here we are assuming there is no renal losses. The slope of this curve will depend upon the rate of net filtration via the capillaries minus rate of return via the lymphatics. If you put kidneys into the equation as well, the curve will look a little bit more steeper because some of the volume is going to be lost via the kidneys. So it takes about 25 to 30 minutes for a crystalloid to escape from your intravascular to your extravascular compartment in a normal euvolumic person. However, if you notice, the plasma volume expansion at the end of brisk 30-minute infusion is 50 to 75% larger than what would be expected. And this is because the rate of your infusion is much higher than the rate of leakage. And once the infusion stops, it will take around 3 to 5 half-lives, so around 90 to 150 minutes before the equilibration occurs till about 20% of the total infused volume. However, if you give the fluid much slower, the degree to which it will increase the plasma volume will be much lower. This is why you always give a bolus of fluid in sepsis, which will improve your intravascular volume quickly, and same goes when you are performing a fluid challenge test. So if you're looking to increase your amount of intravascular volume immediately, you have to give bolus rather than a slow infusion. So let's understand by making a simple model. If you give a liter of crystalloid, it is going to distribute in your vascular compartment, which consists of your arterial, capillary, and veins. There will be leakage via the capillary into the interstitium, and here we'll call intravascular compartment as 1 and interstitium as 2. And lymphatics are going to take this extra fluid that has leaked from the vascular compartment back to the venous system. Meanwhile, your kidneys are filtering the extra fluid that you have infused. So the first phase is the distribution phase, where the fluid leaks from your vascular to your interstitium. We'll call this clearance of the fluid, that is K12, that is filtration in the capillaries. And this is given by your modified Starling equation, as we have discussed before. Under normal condition, the total rate of filtration for the whole body is around 8 liters per day, excluding kidneys, and this amounts to about 5.5 ml per minute. The lymphatic return, that is K21, that means the clearance of fluid back from interstitium to the vascular compartment. This will depend upon the interstitial pressures, lymphatic contractility, and other mechanisms involved in the lymph movements. We'll discuss about this in a separate lecture. At equilibrium, K12 is approximately equal to K21. Second part is the elimination phase, which starts happening simultaneously, and this is through the clearance in the urine, and this will depend upon the renal perfusion, autoregulation, glomerulotubular feedback, RAS and SNS activity, diuresis, degree of renal injury, etc. So T half of the fluid will decrease with increasing capillary filtration, decreased rate of lymphatic return, and increased urine output. So fluid remaining intravascular at time t would be equal to amount of fluid given minus the amount of fluid that has leaked into the interstitium minus the amount of fluid that has been peed out plus the amount of fluid that is returned from the lymphatics to the intravascular compartment. So whenever you look at the T half of any fluid, you have to take all these three clearances into account. Let's understand with some example. In preeclampsia, you develop quite a bit of edema, and it is common to assume that the rate of leakiness is much higher in this condition. However, when you look at the various clearance constant, your K12 is much lower than a normal person, and your K21, that is your rate of lymphatic return, is diminished a lot. Your K10, that is rate of your renal clearance, is higher than the normal person. So the reason why preeclamptic patients are developing edema is not because the rate of filtration in the capillary is increasing. It is because the rate of lymphatic return has dropped by a lot. One of the questions that I will leave you to ponder is, do you think giving a diuretic in this case will help reduce edema in preeclamptic patient? So whenever you ask how long will the transfusion fluid will remain intravascular, always think about K21 and K10 apart from the K12. So now you understand these basic concepts. Let's dig a little bit deeper. The actual fluid compartment are a little bit more complicated. First, the intravascular compartment is made up of arterial and venous compartment. If you remember, arterial is your stressed compartment and venous is your unstressed compartment. Most of the blood is in your venous compartment. And whenever you give fluid, it's going to redistribute in these two compartments depending on the compliance of the vessels and the capacitance of the vessels. Interstitium is also not just one simple big space. It is made up of two spaces, aqueous phase, which is your rapidly equilibrating phase, and a gel phase, which is a slowly equilibrating phase. Remember, in the previous lecture, when we were talking about the interstitium, the gel phase likes to absorb salt and water under certain conditions, and that can exaggerate or shorten half-life of many fluids. Lastly, there is a non-expansile ECF compartment, which has to be taken out of your interstitium when you are doing your calculations. For now, we are also ignoring the incipient losses such as sweating, respiration, and losses from stool and drains, and the water production from the metabolism. Once you understand the concepts in this lecture, you can add these as well for a more complete picture. Also, we are discussing isoosmotic crystalloid. If you use fluids with different osmotic pressure, you have to take the movement in and out of the intracellular compartment as well. So the more detail you're understanding about the fluid and its compartments, better would you understand where the IV fluids will go when you give it to these patients. So let's understand with an example. Let's give a liter of saline to a normal person. When you give a liter of saline, the first place where it's going to equilibrate is between the venous and arterial compartment. Most of the fluid will remain in the venous system because of its large capacitance. And increase in fluid will also increase the perfusion pressures, which will increase the rate of filtration K12. And this will subsequently increase your K21 after some time. As more fluid is filtered, your interstitial pressure is going to rise slightly. That will result in increased rate of lymphatic return. Meanwhile, you are urinating more because of increased perfusion pressure. And as the time goes on, most of the IV fluid will be excreted in the urine. This whole process will take 3 to 5 half-life of the crystalloid. So in about 90 to 150 minutes, person should be back to his baseline and have excreted all the crystalloid. Let's see what happens if you give too much fluid to this normal person. When you give too much fluid, the rate of filtration all of a sudden increases rapidly, and that results in opening of aqueous channels. Because of opening of aqueous channels, you might develop edema in the more compliant areas. When you give fluids too rapidly, this can result in glycosaminoglycan breakdown and deformation, resulting in more negative pressure in the gel phase and absorption of fluid from your aqueous phase into your gel phase. Understand that the fluid that accumulates in this phase is very resistant to diuretics. However, as the time goes on, glycosaminoglycans are going to release water and salt as their structure improves, and this will be peed out in the urine. So if you give fluids slowly, the fluids will tend to remain in the aqueous phase, which will be removed by the lymphatics pretty easily. However, when you give fluids too rapidly and too fast, sometimes you can tend to disrupt the glycosaminoglycans, and fluid can accumulate in this gel phase, which will be more persistent and will take longer to come out. When you give slow infusion, your T half of the fluid is longer. However, understand that slow infusion will not result in that large bump of perfusion pressure. Look at your patient need before you give fluid. If your patient is hypotensive and you want to make the blood pressure better faster, and the patient is fluid responsive, it's always better to give your patient boluses of fluid. If you think that you have achieved good blood pressure and good perfusion, and you still think that the fluids are going to help him, try to give him fluid at a lower rate. Always look at fluid tolerance before you order any fluid. So infused crystalloids will redistribute between the plasma volume and the interstitial space with a half time of 25 to 30 minutes. Therefore, the crystalloids will equilibrate in 3 to 5 half-lives, that is around 90 to 150 minutes, and in this time it will reach around 20% of its original volume inside the vessel compartment. However, given the continuous renal excretion, the normal person will pee it out completely in few hours. One of the main goals of this lecture was to give an idea about how fluids move inside different compartments, and that leakage is not the only part that you need to consider when you're giving fluids. We'll discuss each part of the model separately in our subsequent lecture and then bring all these principles together, how you can use this information to help your patient. My goal was to give you a more complete picture so that you can try to figure it out yourself about the complexities in medicine. I hope that you can see that half-life of fluids is going to vary tremendously depending on so many factors. We'll talk about all these individual factors in our subsequent lectures. These are the references. You can see the links in the description below. Thank you.